hypothermia is, right? The term itself is very self-explanatory. Hypothermia, temperature is lower. But our whole point is how low is hypothermia? How low is dangerously low, when it's life-threatening, right? And what do we do as nurses to assess the patient? What do we do to follow some evidence-based practices to help the patient, getting them out of the danger zone and also bringing a normal temperature in their body? So these are some topics of discussion. So the very first thing would be the temperature, right? That's what the first thing comes to your mind is what is considered as hypothermia. So it is right here, 35 degrees Celsius or 95 degree Fahrenheit. This is considered as hypothermia. But now make sure that you read this, that it says core body temperature, right? Anybody has any idea what core body temperature is? I'm sure you have heard of this terminology as well. What is core body temperature versus peripheral body temperature? That is the opposite of core body. Anyone?
It's the middle part with not the extremities.
Yeah, not the extremities. Okay, all the answers are good. Thorax and rectal, core being the center, and okay, internal organs. That's where I was coming. And as you wrote, so basically the right explanation is that the temperature of the internal organs, right? Liver, your heart, intestine, even brain is considered a part. So this is core body temperature. This is really what we are concerned about. As a medical professional, we are more concerned about core body temperature, right, than peripheral body temperature. And you'll get a clear idea of why we say that. And basically, heat produced is less than heat lost. And we'll discuss some mechanisms of heat production and heat loss. And again, first few slides are going to be kind of review of what we did last semester, but perioperative hypothermia is built on this, strongly build on this concept. And as much as it sounds like, maybe a minor deal, hypothermia, okay, temperature is a little bit low, maybe warm the body somehow, but it is life-threatening, okay? It can cause cardiac arrest eventually. It will cause ventricular fibrillation. So it is life-threatening. So very crucial topic for patient care. So this is what's considered as hypothermia, first of all. And then let's discuss what heat balance is and what causes hypothermia. Now, human body, as you all know, is very sophisticated, right? It tries to at least maintain homeostasis in the body in each and every aspect. For example, the hormone production. We discussed last semester in the concept of regulation and metabolism that all the hormones in the body work on a positive negative feedback system, right? The body tries to maintain homeostasis. Similarly, oxygen, carbon dioxide, body maintains homeostasis. Similarly, for the temperature as well, the body tries to maintain homeostasis. The heat production, some of the mechanisms in the body is basal metabolic rate. So you all know the BMI, BMR, right? And the basic metabolism in the body that is happening at the cell level, right? The breakdown of the carbohydrates, mainly the fats, into energy. Basically, in that process, heat is generated, right? The final product is ATP. From your physiology class, I'm sure you remember ATP, adenosine triphosphate. So that element is built in the process of metabolism and heat is generated. So that is a mechanism of heat production. The second is muscular activity, shivering, right? You all know when we are cold, the first thing happens is shivering. So that's involuntary muscle activity, which generates the heat, right? Any activity, any movement that generates the heat as well. The third one is thyroxine and epinephrine. So these are, again, the hormones which stimulate the metabolism, right? Thyroxine is a thyroid hormone produced by the thyroid gland. Epinephrine, norepinephrine, these are fight and flight hormones, right? Last semester we discussed as well. Epinephrine, norepinephrine. So epinephrine also has a stimulating effect on metabolism. So these are the mechanisms of heat production. Heat loss mechanism, there are four mechanisms: radiation, conduction, convection, and evaporation, right? The little mnemonic, which I did not put it here, is to remember is RECC, rec. Hmm? And this is really a chemistry topic, and but we will try to apply that on the human body in the later half of the discussion. So it is a radiation, evaporation, convection, and conduction, some of the mechanisms. Now let's discuss briefly about the pathophysiology of hypothermia or pathophysiology of thermoregulation. As I already discussed, that the human body, it maintains homeostasis. It works on positive and negative feedback system. So what that means is, outside, if the temperature is cold, right? Here, temperature is cold. What happens is the messengers on the skin, efferent neurons, the messenger on the skin is the largest organ, right? The first protective layer against any bacteria, pathogens, or the temperature. That's the largest body organ, right? It's about 3 to 3.5 pounds weight of the skin of a normal human adult body. And if outside it's cold, or the efferent neurons, they sense that, they take the message to hypothalamus. You must remember that, right? Hypothalamus is the temperature regulator of the human body. So this is the temperature regulator that maintains that homeostasis. So this hypothalamus, it sends signals throughout the body. Various types of changes starts to happen when it's cold outside. For example, shivering, that's the first thing I said, shivering, right? And vasodilation, for example, right here, vasoconstriction will happen, right? Vasoconstriction, why? That the vessels on the skin, they get constricted so that there is less heat loss from the body to the environment, vasoconstriction, right? And also piloerection. Piloerection is that goosebumps, right? The little erector pili muscles, they starts to constrict, and this results in goosebumps. Basically what happens is that those goosebumps, little goosebumps on the body, they trap the air. The air is a poor conductor of heat, right? It's not a very good conductor of heat. So that trap the air, that also helps to keep our body warm. So these are some of the mechanisms that starts to happen when hypothalamus sense that it's cold outside. Heat, it's something different that's going to happen, obviously. Vasodilation will happen. That's why when it's too hot, the body, the face, it becomes more red, because because of vasodilation, more heat now is going to be lost to the environment, which is what we exactly want when our body is hypothermic. But that's a totally separate discussion that we did last semester, so we are not doing hypothermia for this discussion. And also sweating will happen. And so this is kind of the pathophysiology of hypothermia. And types of hypothermia is induced and accidental. So induced is when we deliberately induce hypothermia. For example, in patients with cardiac arrest, there is conflicting research again about the efficacy of induced hypothermia in cardiac arrest. As we discussed again last semester, that induced hypothermia will result in less demand of oxygen in the body tissues. That's why the chances of survival is supposed to increase if we induce hypothermia in cardiac arrest or in neurosurgeries, in cardiac surgeries, right? So that is the induced hypothermia. But today we are more interested in studying about accidental hypothermia, which we are not intending to bring that in the body, but accidentally it's happening. The other name is inadvertent. Sometimes clinically you'll hear inadvertent hypothermia. So that is basically accidental hypothermia. For clinical purposes, it is differentiated into 4 stages. The first stage is very simple, like at home, it's cold, temperature is cold, and we start to shiver. We are still conscious, our body is, the compensatory mechanisms are kind of a little bit activated, and the body is shivering. So that's first stage. So very mild hypothermia, not too dangerous, right? Still manageable. Stage 2 and stage 3 are kind of like moderate hypothermia, which we'll again study further. That patient's consciousness is impaired in stage 2. Now, the less oxygen is going to the brain tissue, consciousness is impaired. And the third one is unable to, a third one is patient is unconscious now, not impaired. Patient is completely unconscious. And now the patient's body is not even trying to generate the heat. It has given up, right? I cannot do it anymore. Now we need to intervene more at this point. We need to actively warm the human body because now the compensatory mechanisms are all gone, right? Patient has vital signs, but they are unable to shiver, right? And the fourth one is patient no longer has vital sign. And you all, as you all can imagine now at this stage is really when we begin CPR, cardiopulmonary resuscitation. Patient does not have a pulse, does not have a respiration. So it is like, the end stage pretty much of hypothermia. And now let's discuss that before going further into the hypothermia. Frostbite, very briefly about the frostbite. I'm sure you have heard of this terminology, but what exactly is it? It mainly happens at the peripheries, at hands or at the feet. When it's exposed to extreme amount of the cold temperature, the tissues, basically the layer of tissues, it starts to get damaged. That's all what frostbite is. Again, there is there is stages of frostbite. This is normal. For example, on hand, I have showing you the picture. Frost nip is when epidermis and dermis is starting to damage. So you see the redness there. And superficial frostbite is you'll see like skin getting now waxy and white because the subcutaneous tissue, the muscles, they have started to get affected now. And deep frostbite is really when the skin starts to move towards the gangrene or necrosis, right? And you all can imagine at this point, the only option that we are left with, gangrene and necrosis, would be the amputation. So this is frostbite, right, on the peripheries. And anybody, can you think of, like, as nurses, what would be our first thought in case we have a patient with frostbite? What do we need to assess? Not in the interventions right now. So what do we need to assess, which could be life-threatening, and which is more important to manage than frostbite at that point? Vital signs. Okay. Yeah, it's indirectly what I'm asking. Core temperature. There you go. Core temperature, right? And so more than the frostbite, now we know that patient's body has been exposed to the external cold temperature. Now, more than that point, more than that part, we are more worried about the core temperature now, because if the pulse is less or it's pulseless or vital, so we need to start managing the core body temperature more than the frostbite. You got the point. And now the risk factors for hypothermia. These are some very self-explanatory risk factors. Exposure to cold environment, immersion in cold water. I want to talk a little bit about that. And the cold water immersion poses more risk than the human body being in cold air. Same mechanism. Air is not a very good conductor of heat. That is why when we have a layer of clothing on our body, a layer of air is trapped in between the body and clothing. That's what keeps us warm. But water is a very good conductor of heat, so the heat will be lost more. So it's a risk factor. Inadequate clothing and shelter, advanced age because the nerves are damaged, sensation is poor, exposure to windy temperature, trauma, spinal cord injuries, because now it's going to affect our ability to send the messages to hypothalamus to really maintain that homeostasis. Traumatic resuscitation. This is really to say the fluid resuscitation more. So when we do the fluid resuscitation, body is at more risk for developing hypothermia. As you can imagine, the cold IV fluid going into the body. Sepsis. Some of you might be thinking, oh, sepsis, infection, the temperature raises, right? Yes, the temperature do raise because the temperature that is a fighting mechanism of body against that pathogen, against that infection, right? Causes vasodilation and moves all our soldiers, our fighting cells towards that pathogen, and that's how the fever helps. But in some of the cases, 5 to 25% of the cases, we see that body temperature actually is lower than blood going to here and brain. And right, so the hypothermia, what happens is some of the cases hypo, but hypothermia is again more dangerous when we see in sepsis than hyperthermia, than the fever. Now, body is not really fighting, right? It's not helping our fighting mechanism in any way. So hypothermia also can happen in sepsis. So we have to be mindful about that. And alcohol ingestion, because it increases the risky behaviors in which hypothermia can happen. Some of the other risk factors are some medications. For example, some of the cardiac medications, some sensory, some medication that affect the sensory perception, some like some general anesthesia, regional anesthesia, respiratory function, some bronchodilators. So all the medication that in any way affect our, cardiac circulation, the sensation, the anesthesia. So all those again pose a risk factor for hypothermia. And about anesthesia, we'll talk in detail in perioperative hypothermia as well. Skin wounds associated with burns. Why it increases the risk for hypothermia? Because now the body is really exposed more to the environment. So more heat will be lost. So we have to be very mindful in cases with burns, right? That we maintain the room temperature or maintain the core body temperature. It's much harder than a normal body. And the other is immaturity of temperature regulatory in newborns. And we'll talk about it in lifespan consideration, why newborns are at more risk for hypothermia. The clinical
I'm sorry.
manifestation.
I'm sorry.
Yes.
Can you go back over why it's more of a risk in abused children?
Oh,
I
yes.
think you might have skipped over that.
Absolutely. Yeah. And thank you for reminding me. So, in abused children and older adults, why there is more risk. So, in abused children, so what the main risk is, we are not sure if there is proper heating in the house, right? We are not sure if in the bedroom they are sleeping, there is proper heat, right? And we are not sure about their nutrition level. So they are malnourished. They are going to be more at risk for hypothermia, right? Maybe outside they are left. So abused, neglected children and older adults. So it itself, it poses a risk for hypothermia. And in the ER, in acute care setting, you'll see more that people who are we don't have to go into the specific medications. There is a question about which medication, but it's just you have to remember that some of the medication that affects the sensation perception or general anesthesia, fentanyl and stuff like that, so they poses more risk for hypothermia. And so one of the intervention related to neglected and abused children would be to collaborate with the social worker, as you can imagine, which we'll discuss later on. But this is why it increases the risk for hypothermia. Now, getting into the clinical manifestations, there's a little mnemonic. There is a whole lot of clinical manifestation, but the first manifestation, a mnemonic to remember is umbles. Umbles, and it is a clinical manifestation for a lot of other things though, but for hypothermia especially, it's considered mumble, fumble, stumble, and grumble. So in mumbling, the patient is now mumbling and not really able to clearly communicate. Fumble is the lack of coordination. For example, touching the index finger with the thumb, touching the nose with the index finger. Their coordination is poor. Stumbles is they are not able to walk, and grumbles is, complaining. So what that means is that sometimes from outside it seems like everything is fine and there is some little memory changes or something like that, but deep internally the body is really fighting to maintain that core body temperature. So that's what we have to be mindful of. So anyways, all these symptoms, if you see now, you might be thinking that how am I going to know if this is hypothermia, is this stroke, is this infection, what is going on? So the simple answer is that if you see any of these 4 signs in your patient, grab a set of vital signs. As simple as that. Grab a set of vital signs and grab some labs, CBC, Chem7, right? Draw some labs, collaborate. And again, you're not going to do it without provider's order. For that, you're going to collaborate with the provider. So you're going to grab the lab. So you'll have a clear picture now, right? What's happening with the body. But anyways, these are the 4 signs that you can remember by this mnemonic umbles, and then getting into the details of clinical manifestation based on the three types of hypothermia is mild, moderate, and severe hypothermia. And I have given you here ranges of that, right? Mild is 89.6, still quite lower, 5 degrees Fahrenheit lower than what normal is. And here is 82.4 to 89.6, and below 82.4 or 28 is severe hypothermia. Severe is really the body is now moving towards like being pulseless, being no respiration, and we have to start the CPR. That's what really is. In mild and moderate, how you can remember is a mild hypothermia, body is trying to compensate really hard to bring the core body temperature to normal, right? So fatigue, slurred speech, poor coordination, confusion. So all these we discussed in umbles. Inappropriate behavior, shivering, tachycardia, and tachypnea. So tachycardia, tachypnea, and shivering, now you know these three are the compensatory mechanism. That means now hypothalamus is really sending the signals to the body. Moderate hypothermia, body is kind of giving up now. The hypothalamus is kind of giving up now, right? Slow pulse and irregular heartbeat. Hypotension, right? No shivering, depressed respiration, right? Depressed mental status. Now you see the compensatory mechanisms are all gone now. They said there's no shivering, no raising the blood pressure, no raising the heartbeat, right? Everything is shutting down. Everything is slowing down, right? Now we have to really get worried about it, and we have to actively start managing that. And we'll talk about the interventions to be done. Cyanotic color, hallucination, coma, and all, very self-explanatory. The oxygen is low, and oxygen to the brain is low in the tissues. That's why it's happening. Now here I wrote ventricular fibrillation. Very briefly, I want to talk about it. And do you think we begin CPR in ventricular fibrillation or no? Any thoughts about it? Maybe you have heard it in clinical areas.
No, you wouldn't do CPR because you still have a pulse.
You still have a pulse. And just I want to talk very briefly about it. So it's not only asystole. Asystole is flatline. When you see flatline on the EKG, in which you will begin CPR, but there is some other rhythms as well in which you will begin CPR. Ventricular fibrillation is one of those. Right? So ventricular fibrillation, and also, we use defibrillator, that's right. And also PEA, pulseless electrical activity. I'm not going to go into too much detail, but ventricular fibrillation is really like that. In next to 1 minute, it's going to be like that. Okay, this is ventricular fibrillation. This is really not doing anything to the body. Now the ventricles, the lower chambers, they are flickering. All that's what's happening. The blood and oxygen is not going to the brain. It's not going to the heart. Yes, you would do CPR, absolutely. And it's not going anywhere, right? Basically, they're going to be pulseless, but on the monitor, you'll see something like that. This is ventricular fibrillation. So begin CPR. That's why I wrote there. Call the cord. Absolutely, call the cord. And also PEA is pulseless electrical activity. You will see something like that. You'll see something like that. Yeah, so this is pulseless electrical activity. Some little electricity the monitor is picking, but it's not really useful. Basically, that's what it is. Anyway, so not just the asystole, ventricular fibrillation, PEA, all these rhythms, you begin the CPR. Lifespan considerations. You might have heard of these mechanisms about this in your pediatric and OB class, but infants are more at risk for hypothermia. Why? They have a larger body surface. If we compare the weight of newborns to their surface area of the body, head to toe, and a normal human adult, the infants have a larger body surface area compared to the weight that they have. So they are more at risk for losing heat to the environment, okay? And also they do not have as much subcutaneous fat, which is insulating, and so they lose more heat than the adults, right? And also the core body temperature and peripheral body temperature has a lot of difference. So more heat is lost from core to the peripheries. So these are some of the mechanisms why infants are more at risk for hypothermia, right? So it's very important to maintain a good normal core body temperature in infants. And they do not have the physical phenomena of heat production, which is shivering, right? You haven't seen any infant neonates shivering. So how they produce heat is by the chemical thermogenesis, by means of adipose tissue, brown adipose tissue. That's a layer of brown fat near the trunk or the neck areas, near the arms. So this is a little brown fat which is lost in that like first few weeks of their life, and but that helps in the thermogenesis, NST, non-shivering thermogenesis, also sometimes called as chemical thermogenesis. And they have little in the activity of the muscles they can do to produce heat, but not like involuntary shivering. That's not there. And so chilling can cause respiratory distress in infants. That's why it's very important they have incubators, especially for the preterm. They are at more risk for heat loss. The incubators, how it works is it creates a layer of warm air around the neonate, around the infant, and which is, again, I mentioned, poor conductor of the heat. That's how it keeps their body warm. So, and for children and adolescents, again, their mass, the body surface area, is less than a normal adult. So again, they are at more risk for heat loss, right? They may not be able to recognize frostbite. What that means is children are playing outside and parents are calling them in, they are not listening. They have lack of knowledge how to protect themselves. The glycogen stores are less. Glycogen store is the excessive energy that we as adults are able to store that in the liver, which later on, if we don't eat, we are able to use that glycogen stores from the liver to generate heat. They don't have that much glycogen stores, so more at risk, right? And the risk, again, abuse, neglect, extreme poverty, adequate shelter, that's always going to be considered as a risk factor for all the lifespans. And for the pregnant women, the induced hypothermia is contraindicated, and there is not much considerations there. It's just that we have to collaborate with the provider for the warming in case they go into hyperthermia, extremely dangerous. And but independently, we need to avoid, but we need to collaborate with the other healthcare team members, with the providers, for the proper ways to warm, for active and passive warming. For example, no direct heat on the stomach, and mainly the warm blanket underneath or something like that. And in older adults, they are at more risk for heat loss, as we mentioned already. Body is less able to maintain the temperature, right? The subcutaneous fat is less. The CNS system is the sensation are poor. So we have to be very mindful about that. And hypothermia can happen in sepsis as well. At that point, we need to actively start thinking about it, because the body is going to go into septic shock at this point, right? If we don't intervene properly. Diagnostic tests are really, the first is the vital signs we check in case we are thinking that it is hypothermia. After that, CBC and Chem7 is your go-to. At 5 o'clock in the morning, everybody gets these CBC and Chem7. This is a biochemistry in which we check electrolytes, we check renal function test, and LFTs, right? And these are your go-to to see, like, what type of, what is going on in the body for the compensation. How can we manage the body symptomatically? Then is the cardiac enzymes, because heart is getting affected. We need to see the cardiac enzymes, the EKG, what's happening there. Coagulation studies and ABG. The hypothermia, it affects coagulation. It increases in it negatively affects the coagulation factors, the PT, PTT, INR. These values will be lower than expected, right? Body is at more risk for blood clotting. So we have to perform the coagulation studies and ABG analysis as well, because the body, because of the more oxygen requirement and lack of oxygen in the tissues, is going to start going into the respiratory acidosis or metabolic acidosis as well. So we need to perform the ABG analysis. And here we need to check for the infection, acidosis, coagulopathy, same rhabdomyolysis. In rhabdo, there is a dangerous protein that's made in the body from the breakdown of the muscles, right? So these are some of the diagnostic tests that we will do. What are the 3 ways of doing patient assessment before going into the nursing process for hypothermia? I discussed that last lecture, so just wanted to ask you that. Any type of assessment, what are the 3 ways in which nurses can perform assessment? Vital signs, okay, very broadly I'm asking, very broadly. Okay, interview, yeah, history or interview, that's the first. That is the first. Observation and history, that is the first. Observation and history, that is the first assessment. The second one, physical exam, there you go, Marta. And diagnostic test, there you go. Yeah, these are the 3. Thank you. Very good. So the first is observation, interview. The second one is physical examination. The third one is diagnostic test. These are the 3 ways. These are only 3 ways that you're going to assess your patient, right? So for hypothermia, whatever we have discussed, you're going to basically check that. These are the observation and patient interview. These are the physical examination. I did not write the third one, diagnostic test, because in previous slides I discussed about it, right? So very self-explanatory. Piloerection, again, this is goosebumps, okay? Goosebumps, little goosebumps, they trap air, which is a poor conductor of heat, and that's how it's gonna help in trapping the heat. And planning. So planning, the recommended rate, whenever you plan or set the SMART goals for your patient of with hypothermia, keep in mind the recommended rate is 0.0 to 2 degree Fahrenheit per hour, not more than that, okay? And because rapid warming of the core is very dangerous. Why? It might stimulate heart to go into cardiac arrest. Okay, it might stimulate heart to go into cardiac arrest. So you have to be very mindful about that. So one thing to keep in mind is patients with hypothermia, we need to be very, very gentle with them. Very, very gentle. No vigorous massaging, no nothing, okay? And when we are transferring them, yeah, absolutely. When we are transferring them from the stretcher to the bed, we need to be very, very gentle, okay? Because we don't want to stimulate the heart basically to go into cardiac arrest or ventricular fibrillation, as I mentioned. Okay, some of the interventions, let's discuss about that. In emergency, as nurses, as medical professionals, or even like, outside you see anybody with the hypothermia, shivering and cyanotic, what can you do? The first is remove clothing. Skin to skin contact is always go to under blanket, okay? To warm the human body. Warm compresses to the, again, very important concept. Very last slide again. Do you have any questions on this slide? And again, few things here and there I have changed, but I have uploaded this PowerPoint into your pre-class and in-class activities. So please refer to that in case you have any questions. All of this information is present in pre-class and in-class activities, okay? If you need to refer to that. And so very important concept is that the core should be warmed first, neck, chest, and groin. So anytime patient with hypothermia, you're not gonna start rubbing the hands. You're not gonna start putting warm compress on the hands or the feet. Because if you do that, the cold blood here tends to go to the core, which is gonna lower the core temperature more. So never ever warm the digits or the peripheries before the core. So always go for the core first, right? That's our main concern. And do not apply heat on extremities, as I mentioned. No application of direct heat. That's really to say, like, the lamp or the direct water, hot water, don't put that. There always has to be a layer in between high calorie beverages and CPR, obviously, if not breathing or not pulse. In the hospital, what can we do? We'll discuss further into detail, but passive warming should be done. and we'll discuss the techniques of that. The room temperature should be at least 82.4 degree Fahrenheit. The warming should be done no faster than 0.5 to 2 degrees Celsius per hour. Rewarm, we can use the warm water for soaking the hands and feet after the core warming, and monitor for the labs and all the diagnostic tests that we mentioned. Other interventions are pain management, collaborate with the social worker in case there is a neglect, okay? And then evaluation. Evaluation, again, I wanna reinforce this point that evaluate not just your goal, okay? Evaluate your interventions. To be effective in nursing process, you need to evaluate your interventions. Your intervention is put a warm blanket over patient's body. So your evaluation would be warm blanket was placed, body temperature raised 0.5 by 0.5. This is your evaluation, okay? Not just the goal. All right, so this was all about hypothermia. Any questions on that before we go into perioperative hypothermia? All right, guys, so, okay, thank you. And should we focus on FNC? What is FNC?
Sorry, on Fahrenheit or Celsius for exam purposes.
Oh, yeah. So really both. Why I say both is we used to use Fahrenheit all the time, and now they have started using Celsius. Some of the other organizations are different, okay? And so I would say both.
Okay,
It is
thank you.
little
Yeah,
fast.
we were at Waterbury last semester, and it was all Celsius, and now we're at St. Mary's, and it's all Fahrenheit.
Or
So
Fahrenheit,
I suppose
absolutely.
knowing both is probably a good idea, right?
Absolutely, absolutely. And that's what I have experienced, actually, a lot of differences. So I know it's a little fast. I'm sorry. It's just that we have to cover the topic, and there is few more slides, and you have another lecture after this. And again, having said that, I'm always available. If you have any questions, you are going through PowerPoint slide, you can always reach out to me with any questions, okay? All right, so we'll get started with the perioperative hypothermia. I'll try to slow down a little bit. And perioperative, and the concept so far of hypothermia was really a revision from previous semester. That was also one of the reasons. And perioperative hypothermia is hypothermia that can happen in preoperative, intraoperative, or postoperative stage. There is a question, that exam question come from the slides. Yes, absolutely, from all of that we are discussing right now. And the little difference between perioperative hypothermia and normal hypothermia is the range. In hypothermia, we said it's less than 35. Perioperative hypothermia is less than 36 degrees Celsius, okay? Because now the body is more at risk for developing hypothermia. Also in perioperative, we need to maintain the core body temperature a little bit higher, because we know anesthesia and everything else is going to pose more risk to bring that. It is 36 for perioperative hypothermia. Okay, it is a very frequent complication. Believe it or not, 50% of the patients do experience some degree of hypothermia, which is totally preventable. I can tell you from my personal experience. During my second C-section, I was shivering the whole time during the surgery. The whole time. I am not even kidding. Because the pre-warming was not done, right? And there was no blanket that was given in spite of me asking. So just from personal example, I can tell you. But if the nurses are a little mindful, now my body was, relatively healthy, no comorbidities. I was able to compensate for that. But now imagine a 80-year-old going for some type of surgery, which is lasting for 4 hours or so. There is no pre-warming done. There is no proper assessment. What can happen to the body, right? More oxygen demand, body is not compensating, anesthesia is there. So it can be very, very dangerous. It can be definitely unstable, okay? So this is perioperative hypothermia. Some of the risk factors involved, patients who already have hypothyroidism. This is not an exhaustive list, really. Just a quick, some of the risk factors are if the patients are pre-operatively, they have hypothermia, they are going for some anesthesia, especially regional, neuraxial, and general anesthesia that basically impairs the signals from the efferent neurons from the skin to the brain. Okay, that also is a risk factor. Infant and older adults, known risk of cardiovascular complication. That means if they have already a risk for cardio complications, if they get little hypothermic, their heart is going to be in more stress. Okay, so that are the risk factors for perioperative hypothermia. Quick quiz: what are the reasons for hypothermia intraoperatively? Why do people get hypothermic? I told you one, anesthesia. What else? No pre-warming, as I just mentioned, happened with me, right? Yeah. Room is cold, relatively cold, to prevent infections. Overexposure, absolutely. Longer surgery, laying in the cold table, there you go, right? And here I have put a lot more reasons why patients are at more risk. Cold OR temperature, as you mentioned. Irrigation fluids, the body cavity, say abdominal cavity is open. Now they are constantly irrigating it, cleaning it with the fluids, right? With the pressure, normal saline, sterile water. So that poses the risk. Skin preparation. We are using antiseptics, cold antiseptics for skin preparing, and that poses the risk. Cold RBCs, effect of anesthesia. Muscle relaxant. When you give muscle relaxant, the body is not shivering anymore, right? So that poses a risk. Vasodilators and exposed body cavity and duration of surgery. These are the risk. Blood loss as well. Yeah, that's a good point, Sonia. So more the blood is lost, and obviously that poses more risk as well. So these are some of the reasons why there is more heat loss. Modes of heat loss, as I was mentioning, this is an important concept that body loses heat by this mechanism. Radiation, this is a mnemonic. Radiation is that body is constantly emitting heat to the environment, okay, from all over the body. This is radiation. Evaporation. What is evaporation? Is that the body, the water or the cutaneous, which we don't even observe from the cutaneous pores or the respiration, the water is constantly evaporating to the environment, and that is one of the mechanism how heat is getting lost from the body constantly. The third is convection. What is convection? Convection, the difference between radiation and convection is convection, the current of the air is constantly moving from directly above the body, okay? And if we are in vertical position, if we are in standing position, then the air current is constantly moving around the body. That is called a convection. That's how the heat is getting lost. For example, a fan is put in the OR or fan is put in the patient's room. That through convection, the body is gonna lose heat. Conduction is a relatively easier concept, I think, to understand. Conduction is that the object has to be in direct contact with the body, okay? Conduction, for example, the the OR table. So we have to be mindful that to prevent the heat loss, which is happening by conduction, we can put a warm pad here, okay? Evaporation, we can keep the body dry. Convection, we can avoid putting any fan or anything in the room. Radiation, keeping the room temperature a little bit at a higher point. The recommended is 82°F in case patients have hypothermia. Otherwise, the OR temperature is really put at like 70 to 75 degrees Celsius. The next is that these are some of the adverse effects that we have already discussed. What can happen if body goes into hypothermia, okay? These are the things that can happen, which we have discussed. The wound healings is poor because the oxygen is not there, the blood is not reaching the tissue where the healing needs to happen, and surgical site infection, mortality, pain, shivering, cardiac events, drug metabolism is altered. So basically, all the reactions in the body that's happening at a gas exchange, the metabolic reactions, everything needs an optimal temperature in human body, which is really from like 95 to 99 Fahrenheit. Okay, and anything beyond that or above that, some type of alteration is going to happen in those chemical reactions that's happening in all the organs in the human body. Okay. Prevention of unplanned perioperative hypothermia. So all three stages are going to be different. In the preoperative stage, we need to make sure that we pre-warm. That's the main thing. Pre-warm the patient, maybe put a warm blanket over them. Temperature should be optimal, core temperature monitoring, continuous monitoring. Intraoperatively, we can use passive or active measures of warming, and we will discuss that in a little bit, okay? And post-operative, continuous monitoring in the PACU or the recovery room, post-anesthesia care unit or recovery room, you'll see there's a continuous monitoring every 5 minutes or so of the temperature, okay? And continuous monitoring is very important. Depending on the core body temperature, then we are gonna use active or passive methods of warming. Ryan, do you have a question? Your hand is raised.
Yeah, forgive me for going back a slide, but can you explain a little bit about how it affects coagulation in terms of, does
Yes.
it decrease coagulation? Does it increase coagulation?
Absolutely, absolutely. It increases the coagulation. So the PT, PTT, INR, it would be lower because it is a more chance of clotting. Okay, so the coagulation factors are inadvertently affected in case of hypothermia. So that's what we need to remember. But again, at this point, I think just remember that inadvertent effect on the coagulation is going to happen in case of hypothermia. Okay.
Okay, thank you.
You're welcome. And so these are very simple, like preventive mechanism in 3 different points of perioperative hypothermia, but we'll discuss how we can do that. Now, application of nursing process. In assessment, assess the diagnostic studies that we just mentioned, head to toe assessment, right? We have to perform head to toe. For example, listening to the heart sounds. Why do we do that? Because obviously, if there is any cardiac alteration, you're not going to hear the lub-dub, right? There's going to be some alteration, abnormal sounds in that. And so you have to perform head to toe assessment. The sensations are going to be altered. The mentation is going to be altered. The pupils eventually are going to be altered, because if the muscles of the pupils are relaxing now at the end, towards the end stage in severe hypothermia, now you'll see the pupil dilation, right? And baseline assessment of the temperature is very important for perioperative hypothermia. Assess for certain chronic conditions. We have discussed that. Some of the metabolic conditions, for example, hypothyroidism, hyperthyroidism, metabolic disorders, respiratory conditions, cardiac conditions. If patients already have these comorbidities, we have to be very mindful that they are at more risk for hypothermia. And if hypothermia happens, they are going to be at a more dangerous consequences of that hypothermia. As I just mentioned, like I was shivering the whole time. My body compensated, but some patient who already has these comorbidities probably won't be able to compensate. Okay, so this is where our nurses play a crucial role, and this is all nursing. Whatever we are talking here is all nursing. Assessment of the patient, maintaining the core body temperature, really nurses' responsibility. Okay, more than the providers, I would say. But again, everything is a collaborative process in healthcare. Assess for traumas like burn. They are more at risk factor. Warm the IV fluids and blood product at least 37 degrees Fahrenheit, we say, right? The fluids, crystalloids, RBCs are going to be cold, so we have to be mindful that we warm it. You have experience probably in the hospital, every time you're in clinical rotation, you flush the IV with the saline. Patients always say, oh, it feels very cold. Why? Because now that temperature is lower than the core body temperature, right? That's at room temperature, which is like 70, maybe 68, 72. Core body temperature is 90, 98, right? That's why it feels cold. So we have to be very mindful about that as well. Some of the other interventions are pre-warm the patient prior to surgery, use active and passive warming mechanisms. We will discuss what those are. Ambient room temperature is evidence is 70 to 75, but if patients already have hypothermia, this is for prevention. If already have hypothermia, around 82. 80 to 82 degree Fahrenheit. Okay, this is where we need to keep the room temperature very warm at this point. Oxygen therapy, medication to treat shivering, and this is the forced air blanket. As you can see, I have put in the picture. You have a question, Denise?
I do. Why would we give medications to treat shivering when shivering is helping to warm the body?
Thank you. Yeah, that's a great question. And so why do we give it? Because the shivering, it it increases the oxygen demand of the tissues. Although it is trying to keep the body warm, but at this point in the perioperative, in the intraoperative, we are not just the shivering is not going to help the body. We as healthcare professional need to intervene with passive and active modes of of giving heat to the body. Okay, shivering, what it's gonna do is more than warming the heat, warming the body core temperature, it's just gonna increase the oxygen demand. That's what happened with me. Now I feel so bad that I was shivering the whole time. Probably the oxygen demand was too high at that time, and but with little be mindfulness, it can be preventive. And this is a forced air blanket, guys, and so continuously through this little hose, the air is being forced, the warm air, and it's really a convection mechanism of giving heat to the body, because air insulation is put over the body in forced air blankets or forced air warmers. Okay, and guidelines to measure the temperature, very self-explanatory. In perioperative area, 1 hour prior to transfer. In the holding area, we measure the temperature. Immediately before giving anesthesia, 15 minutes when forced air warming is used. In PECU, every 15 minutes, but it's a continuous monitoring as well in the PECU that we see often, and at the level of discharge, the point of discharge from the PECU. So we need to have a very good monitoring system in place. These are some of the, you might be thinking that core temperature, how do we do that in the OR? So these are some of the modes of measuring the temperature. Nasopharyngeal. And so what they do is that there is a little disc, I have shown you in the picture, little disc catheter that is inserted into the nasal cavity. And here it is connected to a monitor, okay? And it continuously gives you the reading. In some of the surgeries that are long and depending on comorbidities, the providers, the surgeons, they do choose the method of this monitoring, okay? And they do insert this catheter. Esophageal monitoring, insert the catheter into esophagus. Axillary, you all know, bladder, right? So the catheter can also be inserted into the bladder through the urethra, and that can be connected to the monitor. It will give us continuous monitoring of core body temperature. Forehead can be used, tympanic can be used. These are some of the like non-invasive methods that we already use. Depending on the surgery, depending on the patient, we can do that. Myocardial is inserting a catheter into myocardium, into the cardiac muscles. Skin and rectal. Okay, these are some of the methods that you just need to be aware that we can use for monitoring of the temperature. Now, as we talked a lot about, warm the patient, we all know in hypothermia, we need to do that. Perioperative hypothermia, we need to do that. So some of the methods of doing that is the first classification is passive and active. Passive is that there is no continuous heat that is given to body, okay? So we put a warm cotton blanket over them. We put socks, head covering, surgical rib. Very simple, right? We as nurses do that all the time on the floor, in the OR also we need to do that. Active is that continuously you are giving some type of heat. Okay, it can be internal, it can be external. Forced air blanket, which is also called the bear hugger. Also, sorry, it's a BAIR, guys. There's a little correction. BAIR, bear hugger. It's a bear hugger. And hot dog. This is again another type of forced air blanket. Warm IV fluids is internal active method of warming, and conductive fabric devices, which is mentioned right here. These are all active methods of warming. We are actively giving some type of heat continuously to the body. The other classification that can be done is convective warming and conductive warming. As we already mentioned, conductive is relatively very simple to understand, that underneath the body, over the body, we have put a layer of some fabric which is continuously delivering heat, and cold body is in contact with that surface, and it is continuously giving heat to the body. Okay, there is an exchange of heat. Energy cannot be destroyed. Energy can change form, can be transferred from one device to other, right? That's the basic mechanism. So gel pad, table pads, electric pads, heated water bottles, water mattresses, these are some of the conductive methods of warming. Convective is that over the body we have created a layer of air, right? Insulated air, warm air, through which there will be convective um, mechanism of warming it will use. So basically all the forced air blankets you'll see in the hospital, bear huggers are very commonly used in the ER and on the floors as well. And so those are all the methods of convective warming. Okay, there are forced air gowns as well, which I have never used. Honestly, I have used over the body blankets and under the body blankets. They are both considered active. Yes, Eileen. So convective warming, conductive warming are both considered active methods of warming. Okay, these are type of the warmings, and you're welcome. Thank you. That was all about perioperative. There is no pharmacology. So to know even one life has breathed easier because you have lived, this is to have succeeded, right? Everything that we are doing, all the concepts we are studying. So basically, well, we are helping saving lives, right? Breathing people, better. And this is to have succeeded. Thank you, guys. And now I open the session for questions. I'm a little over I was planning to end it at 10:25. Thank you. And just very quickly in 1 minute, I'm going to guide you for so for the antibiotics, for the infection, I have created a document to help you with like very common drugs that you need to learn, and also the little mnemonic that you can use. So it is in the infection under the concept of infection on your blackboard. And also when you go into the prototype drugs, you just for the prototype, the main things that you need to focus is administration alert, adverse effect, interaction. I will put that everything under the concept of infection to guide you a little bit better. If you still have question on that, please reach out to me. Feel free, okay? All right, guys. So if there's no question, thank you, and you can take a break. And okay, so you can take a little break. And Dr. Murphy has wrote there. Next session will begin at 10:40. Thank you so much, guys. Thank you.
Yeah, okay. I was muted. Okay, I'm starting over. Thank you. Sorry, because okay. Today we are talking about reproduction and sexual health as a concept, and we are talking about several exemplars: menopause, osteoporosis, endometriosis, uterine fibroids, and erectile dysfunction. So, as you know, we have the concept of reproduction and sexual health, and these concepts are in your course, and you have your cards. It really makes me happy when I see that you're using them in simulation and in clinical to develop your plan of care for your patients. I do think it's really helpful when you're thinking about what else could be wrong with the patient, what you should be doing about it, and what the concerns are as far as what you're trying to prevent those negative outcomes. And keep those into consideration as we talk through these different concepts. So the first one that we're going to talk about is menopause. So the big thought about menopause is the sensation of menses. And a year after the woman's last period, 12 months, that's what people think about as menopause. And that's actually the definition is really postmenopause, that you've got premenopause when the secretion of the hormones is, I'll say, erratic, and you have started this, you may not have symptomatology yet, but those hormonal changes have started. And then you've got perimenopause, where it's the entire period, and you've got the symptomatology that we're going to be talking about. It does happen. Every woman is different, the same as the start of menarche. The time of that is, adolescence, but that's a big time frame. The average is 45 to 50, but you'll find different time periods in different textbooks. There are physical changes, in as much as there's changes when a girl goes through menarche. It's kind of the reverse, where those physical changes that occurred because of the decrease of hormonal changes, you have physical changes, and you also have psychological changes. The treatment can be hormone replacement therapy, but there's a lot of nursing considerations as well. And so I like this picture because it does help explain premenopause. There aren't noticeable changes, but as we talked about, the hormones start to shift. Perimenopause usually occurs in the 40s. You can experience irregular periods, and they can be significant, where a woman's period bleeding is incredibly heavy, and then there could be a missed period. But again, postmenopause is when it is 12 months without a period, and it can happen where a woman has several months of no periods and then a period. And That's where you've heard the term a change of life baby, where someone maybe thought that their chance of getting pregnant was very little. And then guess what? They're pregnant. Okay. So the symptoms, the psychological can be mild to severe and also really debilitating. You can have hot flashes, night sweats. So consider going back to last semester when we talked about sleep and comfort. It can be very debilitating as well, these hot flashes and night sweats, because it interferes with the woman's ability to be able to rest and be comfortable, to recuperate and have that cognition in the morning and during the day. Again, irregular menstrual cycles, and due to the hormonal changes, you can have vaginal dryness and also bone mass loss. I have, okay, as well, depression, mood swings, irritability, agitation, insomnia, and fatigue. There's associated issues related to nutrition, bone health, which is why osteoporosis is included in this, heart disease prevention, so considerations related to the hormonal changes and whether or not the woman is going to be on hormone replacement therapy, because there's concerns about blood clots and other issues. Weight management, because with menopause, it's very common that increased weight occurs. Hormonal balance and cancer screening. And again, the treatment can be hormonal replacement therapy, but there's a lot of nursing considerations that we use for education for the client. Okay, first question. Oh, I forgot my sound effects. I'm working too many things. Okay, first question, and I'm going to put the poll up. 1 second. I'm not going to add. Can I do this? Oh, I can't do this. Hold on. Okay. First question. I'm going to put the poll up. Don't vote yet. A client is experiencing menopausal symptoms and asks what can be done to help control the symptoms. So what interventions should the nurse recommend? Select all that apply. Dressing in layers, avoiding sexual intercourse, engaging in regular exercise. D, drinking cool liquids. E, increasing caffeine intake. So is your answer A, B, C, D, E, C, B, B, C, and E, C, A, C, D, or D, A, C, D, E? Okay, here's your response. That music is anxiety provoking. Go a couple more seconds. I've got 45 of you have not voted. How are you going to be a millionaire? Okay. Whoops. Whoops. Okay. I'm going to show the responses. 27 don't want to be a millionaire, but the majority of the people did pick number 3. One person picked all of the above. A couple of people picked, and I know you can't see the responses when the polls are up, and I can't figure out how to do that better. So let's talk about the answers. Dressing in layers. It seems that most people liked that. And the idea with somebody who is menopausal or perimenopausal is that, you know, those hot flashes and hot and cold and sweat and all of that can create quite a challenge. And so dressing in layers with sweaters and scarves that can come on and off can be a big help to their comfort throughout the day in a variety of environments. B, avoiding sexual intercourse would not be something that we would educate a client on, but we should be able to have conversations, and we're going to talk about how to do that in a little bit, but having conversations about issues and concerns and maybe modalities to adapt related to the symptomatology. Engaging in regular exercise can be important, one for psychological well-being, but also considerations related to that weight management that we talked about. Drinking cool liquids can help with those hot flashes. And increasing caffeine is probably never going to be a right answer for anything, right? But also the irritability that occurs for someone who's perimenopausal can be a concern. And so adding more caffeine related to that would probably make matters worse. So A, C, and D are the correct answers. Okay, let me close this. Okay, so pharmacology related to menopause. There's a couple of different types of medication treatment, and one is just estrogen alone. And there are considerations for the client because of the increased risk of stroke and clot disease. We need to make sure that the client doesn't have an increased risk of breast cancer or heart attack. So do they have a history of smoking, for example, which we know will increase the risk? Do we know it? Have they had a previous heart attack? Those are considerations as well. So the estrogen will relieve the symptoms of menopause. And again, increased risk of myocardial infarction or a heart attack, stroke, breast cancer, dementia, and then blood clots. Risk for side effects are higher in a female greater than 60. But the research says that a female between 50 and 59 had a slight decreased risk of the adverse cardiovascular events. But again, that's a provider decision and a conversation with the client about the series of their risk factors and family history and all that kind of stuff. Estrogen alone increases the risk of stroke and thromboembolic disease, but doesn't have an increased risk for breast cancer or MI. Then there's also an estrogen progestin combination, which has less risk of osteoporosis fractures, such as hip and also colorectal cancer. So there's a lot of considerations that are going to be very specific to the client, and a conversation with the provider, again, about family history, the client's history, and then having a very educated conversation about whether or not the medication is going to be prescribed and also for how long. Ryan, did you have a question?
Yes, on that last slide, I apologize. I'm a little confused about, it says at one point that increases the risk of MI, stroke, breast cancer, but then later it says it does not have an increased risk for breast cancer or MI.
Hold on one second.
And maybe I'm reading it wrong, but I just want to make sure that I'm clear.
You know what?
on
Let me
that.
clarify that. And I wrote that, and it made so much sense when I wrote it. I'll get back to you about that tomorrow, okay?
No problem. Thank you.
Thank you for asking.
Yes.
Okay. There's also estrogen and progesterone hormone hormone replacement therapy. Again, there's side effects related to that. But there's also benefits, whether or not because of the decreased risk of hip fracture and colorectal cancer. But again, the prescription and the prescribing is a conversation between the client and the provider, and the client needs to make a very educated decision. And also the conversation is about the length and the duration of the treatment. And they'll at some point maybe titrating the estrogen, because so that slowly, so that the symptoms of menopause don't come rearing back and the patient is then uncomfortable. So, if you titrate them down, the symptomatology might be manageable. Okay, next question. Okay, I'm going to leave this up for a little bit for people to look at all of the different answers, and then I will put the poll up, okay? So, which health promotion intervention should the nurse discuss with a client experiencing menopause? 1, undergo hormone replacement therapy as soon as possible. B, wear tight-fitting clothing. C, eat more estrogenic food. And there is a diet component, and there is, of course, now I'm telling you it's the answer. But there is a diet component. There are some foods such as soy, brown rice, that we could educate our client about for their intake, which that might offset some of that symptomatology as their estrogen level decreases. D, so clearly C is the right answer. D, avoid alcohol and cigarettes. E, use water-soluble gels to increase vaginal lubrication. Okay, so I'm going to leave this up for about 10 seconds so that you can figure out what answer you want to choose. Apparently I have the British version. Okay, now I'm going to put the poll up. Now you're going to vote A, B, C, or D. Yes, Ryan?
Sorry, I clicked the wrong button. I meant to go for the poll.
Oh, okay. All right. I thought maybe you couldn't see the poll. So you can see the poll?
Yes,
It
ma'am.
won't let me respond.
Poll's not working.
Yeah,
It's
I
like,
can't.
you can't
Gosh,
select.
epic fail. Okay. All right, then vote in the chat box. Thank you. Okay, I got a lot of A's, a couple of C's. Okay, so let's see. And the answer is A. So, undergoing hormone replacement therapy as soon as possible, it may be controlled. The patient may not be uncomfortable, may not be bothered by the symptomatology, right? So if we can do education about, for example, not wearing tight-fitting clothing, dressing in layers like we've talked about, those estrogenic foods that are in C, the symptomatology may be lessened so that the woman is more comfortable. D, avoiding alcohol and cigarettes is always, it's always the right answer, but for so many different reasons. And for today, it's related to irritability. We're concerned about health, etc. And then E, because of the changes that happen related to a decrease of estrogen, vaginal lubrication significantly decreases, and sexual intercourse for the client may be very uncomfortable. Okay, so we're going to talk about osteoporosis, which is related to menopause because of the decrease in bone mass related to the decrease in estrogen that occurs. We know that it can cause bone fragility, and our patient is at increased risk of fractures. It increases after menopause due to the estrogen deficiency. And if your diet is already deficient in vitamin D and calcium, then you're even at a greater risk for osteoporosis. So what type of prevention do you think that we should put into place? I'm going to ask you to put that in the chat box. What type of education? So I've got vitamins, I've got supplements, vitamin D. And also consider that this conversation about vitamin D and calcium and good nutrition really has to be about a lifetime of good nutrition. And it's not nearly as much. I understand about supplements. I'm not saying that's wrong, but if our client has good nutrition through their lifespan, because one of the things that occurs with clients when they do weight reduction is it's pretty easy sometimes to just take out milk, right? Or dairy. And do you have a lifetime of calcium deficiency? And then vitamin D is also important. It's important for mood. It's also important for the uptake and the absorption of calcium. So, a vitamin D supplement, there are serum blood levels that can be obtained. And also there's just having somebody go outside. You need very little time outside, like 20 to 30 minutes outside will give you the amount of vitamin D that you need. So again, a conversation with a client about time that they spend outside, right? Nutritional guidance, a diet intake or a diet diary can be really helpful. And also having that conversation with our clients very early, not when they're perimenopausal, but when at every intervention or interaction that we're talking to them and talking to them about their diet and their intake. For today, we're going to talk about calcium and vitamin D, but promoting good nutrition. So we can have loss of height. So we've seen vertebral collapse. So this picture here really does demonstrate really well. And I'm sure you've seen some older adults that have a hunchback, and it's really related to the vertebral collapse. And our patients get shorter because of this. But it's also very increases the difficulty in walking. And as Marlene's talking about, fall prevention. So you can have kyphosis or lordosis. You can also have low back pain. So consider that picture on the far right and consider that person's mobility and stability and where their weight is. And so now are we changing the weight distribution? And also, are you having back pain because of this vertebral collapse? And also fractures of the forearm, spine, hip, any, body parts. What type of diagnostic testing do you think that we could do for osteoporosis? Yeah, bone density. And that's again a conversation with the client and the provider about doing a bone density test, often done when someone is postmenopausal, but you will also see that if a patient has fractures, more than the average person, that they may order a bone density. Blood work as well, because we can do a vitamin D level. And again, a conversation about intake and whether or not supplements are necessary. I'm sure there's a 24-hour urine, but I'm not sure what they would be testing for. What do you think they would be looking for, Marlene? maybe calcium, but I think that a serum would be more important. Okay. Thank you. All right, next question. A client is experiencing menopause, is concerned about the loss of height. What change should the nurse explain as being responsible for this finding? Hormonal changes affect muscle strength. B, menopause can lead to osteoporosis, which can lead to fractures and kyphosis. Please tell me I did a good job today. C, bone changes cause scoliosis. D, menopause can lead to poor nutrition and decreased bone density. Go ahead, vote in the chat. I've done my job. So yeah, it is B, because it is osteoporosis, lead to fractures and kyphosis. Hormonal changes don't affect muscle strength, and menopause doesn't lead to poor nutrition. Okay, it's, thank you. Ta-da! So what are some of the assessments outside of osteoporosis that we could do for a client? What ideas do you have? Family history, age, diet, excellent. Activity level, because as we talk about, weight-bearing activities are incredibly important and encouraged for a client who, for everyone, but to ward off osteoporosis. Carisi, why is type of work important? Always smoking, Giovanni. Always smoking, right? Let me see. What do we have? Age, family history, diet, and I would say current and over the lifetime. And think about the economic impact too, because dairy products aren't cheap either. Look, just doing something as simple as looking at their posture. Absolutely, Sonia. Smoking, always smoking. Type of work, smoking, observation. Menstrual history. So we want to know if our patient is perimenopausal, postmenopausal. Alcohol intake, absolutely. Okay, so let's see if we've got them all. Age, yeah, risk factors, history of fractures. I didn't see that in the chat, but it would be important to know if our client has had many broken bones. And there's, I fell, off a porch and broke my arm is different than, I tripped and bumped a table and broke my arm. Okay. History of fracture, smoking, alcohol use, diet, menstrual history. I saw last period in there. Activity we talked about, and also low back pain. Stephanie, did you have a question?
No, that was before from the poll not working. I had my hand up. Sorry.
Oh, okay. It just popped
I don't
up
know how.
now. So
Oh, did it? No. Okay.
yeah,
That's weird.
no problem.
All right.
No problem. Okay. Why alcohol? Because always smoking and alcohol, but also alcohol often, if your client has excessive alcohol intake, often speaks to is an indicator of poor nutrition, that they're using their priority is alcohol over food. As well, there's some malabsorption related to alcohol use as well, because kind of wrecks your liver. So yeah. And I'm not talking about casual alcohol intake. I'm talking about a lot of alcohol. And that's why when you go to the providers, it asks you about your alcohol intake and it asks you about how many drinks a week or a month or whatever the time frame is. And the provider can use that information to have a conversation about alcohol intake and the focus of the visit and provide guidance. Okay, so what are some safety concerns with the older adult and osteoporosis? Put those in the chat. Okay, so we've got falls, but what else can we do? Contributing factors, I think, is probably the better question to falls related to the client. So age, but wait, there's more. Think more holistically. So yep, safety concerns in the home. But wait, there's more. Yeah, there you go, Sandy. Vision. So think about our clients that have or need glasses, whether or not those glasses are even clean, right? They're a bit vision. So adaptive equipment. So if they have a walker, Sarah, or a cane, or what if they need them? Do they know how to use them right? How many times have you seen people on crutches? Like we used to have crutch walking physical therapy sessions, and now we just give crutches. And sometimes it's a little frightening. Absolutely. Other medications that our clients are taking that can cause things like dizziness or fatigue. Okay, loss of balance, inner ear disturbances, medications that can cause loss of balance, any other comorbidities, neuromuscular dysfunction like multiple sclerosis or anything like that that may cause weakness, dementia because confusion may lead to falls, immobilization. We know that muscle weakness can occur with immobilization. Again, we're going to talk about weight-bearing activities that can help increase the perfusion or maintain the perfusion for bone health. And we've talked about medication. Stephanie, do you have your hand up?
No, let me try to. All right, I'm going to try to.
I
put
just
down.
put it
Okay,
down.
it keeps going up. All right, I didn't. I
Okay.
swear I didn't touch it.
Are you
I
at
think
your house just waving a lot?
I know. Doing my exercises. No, kidding.
Do weight-bearing activities, Stephanie.
Right.
Okay. All right. So there are a lot of concerns with an older adult, and these are just some of them. Some of these we can fix, right? We can do an intervention to get our patients' vision tested to make sure that they can see clearly. We need to make sure they have their glasses if they need them, and we need to make sure that they're clean. How many of you have had a patient in the hospital that have had glasses on that are utterly filthy? Right? And you don't even know how they're seeing anything. Okay, I've got a couple of real quick yeses. And you clean them off and they think that you're amazing. And you are. And I'm grateful that you do that. Okay, next question for $500. Which exercise should be recommended for bone health for a client with menopause? A, yoga. B, swimming. C, karate. D, stretching. So think about the parameters. We've got a lot going on here. I see A, B, C, D picked. Keep going. C. This is not select all that apply. I did see somebody pick all of them. You got to pick one. I see a lot of A's. I see a lot of D's. I see some swimming. A couple of karates. Okay. Who wants to say where they picked A for yoga?
I'll speak if anyone else wants to, but I put yoga because it's really the only one that's, I mean, karate is weight bearing technically, I guess, but that could be a little dangerous if you're throwing your limbs out kind of erratically. But so I thought yoga was the only one that really you're bearing weight, you're in push-up position, you're improving your, risk for osteoporosis by doing that. Whereas swimming is non-weight bearing and stretching obviously too.
Okay, so you've just answered all of the questions. So yoga is, and so we have to consider whether or not it's weight bearing, because some may not be, if like you're just sitting, right? But the other concern is you don't want some of those awkward positions if your patient has significant osteoporosis. So yoga can be a good idea, but there needs to be a conversation.
So isn't yoga and stretching very similar?
It is. I was getting to that.
Okay.
Yep. So you want to counsel the patient about awkward positions and a risk of possibly, concern for fractures, which is why karate isn't a good idea, because of the forcefulness, and especially if you're doing any kind of contact because of risk of fractures. So yoga and stretching can both be the same kind of idea. So they're both correct. Don't hate me now. But it is a stronger conversation with the client about making sure that it includes weight-bearing activities. Okay. And then the other thing is swimming is a wonderful activity. So if we want to talk about weight control and all of that, absolutely. But it's not a weight-bearing activity. Yoga does help with posture, but I would think stretching does too. And with karate too, my family did karate. There's like punching bags and those kinds of things, which I think could be very traumatic with somebody with osteoporosis too. So I think karate would be off the list if you had significant osteoporosis. Okay, so one of the common fractures with somebody with osteoporosis is Colles fracture, and it's the fracture of the distal radius. So, see the X-ray here, and see the little fracture there? I love looking at X-rays. So, how do you think that this fracture occurs? Yeah, exactly, Julianne. Thank you. So breaking a fall, somebody goes to fall and the reaction is to put your arms out. And so this is where Colles fracture occurs. So safety is critically important. So fall prevention is really important. And we're going to talk about more probably tomorrow at this point about surgical menopause. And surgical menopause is when someone has removal of their ovaries very early for a variety of reasons, which we're not going to talk about. But surgical menopause is the ovaries are removed and then you have that decrease of estrogen. So that's a client who should be started on hormone replacement therapy. Imagine someone who's 20, 30, early 40s and has their ovaries removed and has that decreased estrogen. We're setting them up for osteoporosis. Okay. So we're going to spend a little bit of time talking about endometriosis, which is endometrial tissue that is present outside the uterus. And you have this secondary dysmenorrhea, which is the hormonal changes that occur that cause a woman discomfort during their menstrual cycle, where you have that inflammation, irritation of the tissues, and bleeding. It occurs in this tissue that's outside of the uterus, so that a woman who has endometriosis can have incredible discomfort related to the hormonal changes that occur, and it can be very, very debilitating to the client as far as on a monthly cycle being incredibly uncomfortable. The other component is, if you think about the irritation and the bleeding and all of that that occur in all of these other tissues, that you have scarring, so related to the inflammation. And so there's a lot of consequences related to, first of all, dyspareunia, which is painful intercourse, but also conception issues, because if you have scarring, and it can occur around the tube or in the uterus, and those, or outside of the uterus, you can have either blockage of the egg going through the tubing, or you can also have implantation difficulty. And so somebody who has endometriosis, there can be a lot of health concerns, comfort concerns, lifestyle concerns related to the client, and also the degree of how much tissue is involved. So there can be medical treatment. What causes it? Life. It is just a deposit of this endometrial tissue outside of the uterus that occurs in the woman. Okay, and then we've got fibroids that we're going to talk about. So another concern is there's different types of fibroids, which you don't need to know the different types, but there's gliomas and myomas and all of these things. And it's really related to what type of tissue that it's made out of, whether or not it's like more fat tissue or muscle tissue and those kinds of things. And there's also ovarian cysts, which again, you don't need to know the difference between follicular or luteal, but just if you look at this picture and the different places that fibroids can settle, you can see where they can cause problems for the woman as far as painful periods, as well as increased bleeding. And you can also have problems with getting pregnant, because the egg can't implant into the uterine wall. No, I don't believe they can be caused by trauma. They're just something that evolve in the woman, like it's like from their original gene pool. I don't believe that these are caused by trauma at all. So here's a picture of a fibroid, which is really yucky looking, but you can see that the length of it, right? It's kind of pretty long. And then here's another one, equally as unattractive. But of course, I saved the best for last. Look at this puppy and how big it is. And can you imagine that being in somebody's abdomen, the discomfort that it would cause, the bleeding that it might cause? I would say they'd probably just lost about 10 pounds, right? So much, concerns and issues. I think those might, I'm just making it up, but those kind of look like cysts. So one of the treatments for fibroids is, so there is surgical, well, they'll remove the fibroids maybe, but there's also what's called uterine embolization, where they'll put a catheter into the femoral artery and feed it towards the fibroid, and they put plastic particles in, and they essentially cut off the blood supply. And then the fibroid, it dies. I've taken care of women that have had this done, and for about 24 hours, it's pretty uncomfortable. And then after that, they feel perfectly fine. Admitted the women for pain management for less than 24 hours post-operative. No, it doesn't fall out, because depending on, if you go back to this picture, right? Oh, no, not this picture. Hold on one second. It just kind of dies and gets reabsorbed. So that if you look, there's like a lining of tissue here. They don't fall out. Can they occur again? I don't know the answer to that. I'm thinking you might be able to develop furthers, or that there's some that weren't causing a problem that can cause a problem. Okay, last question for the day. Which statement by a client is correct who is experiencing symptoms of menopause after an oophorectomy, which is their ovaries have been removed? A, since my uterus has been removed, the symptoms of menopause have started. B, surgical menopause is usually less abrupt and should subside quickly. C, removal of ovaries has caused abrupt onset of menopause and the symptoms can be severe. D, removal of my fallopian tubes has started surgical menopause and the symptoms start quickly. There you go. So yeah, an oophorectomy is the removal of the ovaries, and when you have a surgical removal, the symptomatology can be quite severe. So again, if a woman is young, there's a conversation with the provider about hormone replacement therapy. And tomorrow, look forward to erectile dysfunction and several case studies that we're going to talk about and apply the information that we learned today. And I moved the answers around, but it is removal of the ovaries. And symptoms can be severe. Somebody had their hand up.
It was me, but you already addressed it. I was just wondering which was the correct answer, but thank you.
Yeah, no problem. All right, everybody, I'll see you tomorrow. I didn't notice either, Nicole, so sorry.
Professor, can you upload this PowerPoint with all the questions and answers?
I don't, after tomorrow.
Okay, thank you.